Thank you for joining our session today. My name is Meg Sate, and I'm moderating the session with Zachary Sellers. This is the Symposium Updates in CF Liver Disease. We have some great talks for you today. We will start with Role of Imaging for CF-Associated Liver Disease Abnormalities by Dr. David Asias, Obliterative Venopathy and Portal Hypertension by Dr. Suresh Kumar Pali, What is Advanced Liver Disease and How is it Managed by Dr. Jay Freeman, and CFTR Modulators and Liver Function Tests by Dr. Vanya Kasper. Thank you to all our speakers, and we hope you enjoy our symposium.
Hello, my name is Dr. David Assis, and it is an honor for me to be able to present this discussion on the role of imaging for cystic fibrosis-associated liver abnormalities as part of the symposium on updates in CF liver disease. I have no conflict of interest related to this presentation, and I am a past recipient of the CF Foundation's Digest Award. What I'd like to do in this discussion is briefly talk about the role of imaging in the changing landscape of CF-associated liver abnormalities, discuss some of the indications for imaging studies, some particularities of imaging modalities such as ultrasound, MRI, and the non-invasive measures of fibrosis, as well as some thoughts on the future of imaging in the management of liver disease in CF. First, I think it will be well known to this audience that our understanding of the epidemiology of CF in general, and also that of CF-associated liver abnormalities, is changing rapidly. This is a wonderful development, in part because of the increased survival and improvement in clinical outcomes for our patients. Clearly, CF is not just a disorder of pediatric persons anymore, and so as adult patients continue to live longer, CF and the awareness of the involvement of CF in the liver needs to adjust. One key study of over 3,300 patients studied in over 38 centers in France looked at the increasing prevalence of CF with liver abnormalities in patients. In this cohort, patients with pancreatic insufficiency born after 1985 were followed retrospectively before 2004 and prospectively after 2004. The key finding from this study was that nearly 33% of patients had manifestations of liver involvement already by age 25. And furthermore, 10% of patients had severe disease by age 30, including manifestations of portal hypertension and/or cirrhosis. Therefore, as patients with CF continue to live longer, we need to be increasingly aware of the manifestations in the liver and use imaging modalities in an efficient way to diagnose and monitor these patients. So therefore, how can imaging help in the diagnosis and management of liver abnormalities? One, it may be useful in the screening of patients with CF, including an ultrasound finding, for example, of heterogeneous liver versus homogeneous liver as an initial baseline screening modality. It has a clear role, of course, in the diagnosis of patients with liver abnormalities, finding, for example, steatosis or fatty liver, biliary strictures, and hepatic lithiasis. Staging. It is important for those with a diagnosis of CF-associated liver abnormalities to have imaging studies as applicable to help in the distinction of cirrhosis from a normal liver, as well as manifestations of portal hypertension. And lastly, there is a clear role for imaging in the monitoring for progression of patients who may have mild degree of fibrosis at baseline, but might be at increased risk of fibrosis progression over the subsequent years. Some clinical scenarios where liver imaging can be considered. Clearly, the presence of pain in the right upper quadrant, which could raise concerns for hepatic and biliary abnormalities, along with pruritus or itching. An abnormal physical exam, such as hepatomegaly, splenomegaly, and jaundice. Clearly, we would like to make the diagnosis of CF-associated liver abnormalities early, but at the very least, an abnormal physical exam should prompt an imaging study. And the more complex discussion of how to integrate ultrasound and even MRI in the evaluation of abnormal liver tests, and of which more I'll have further discussion briefly. Let's start then with abdominal ultrasound. It is very clearly the most accessible and suitable initial method to assess the abnormalities of the liver parenchyma and to evaluate for signs of portal hypertension. Imaging abnormalities on ultrasound often precede any clinical signs or symptoms, and this is a well-known fact in general for chronic liver diseases and also for CF. We should acknowledge some limitations of abdominal ultrasound, such as the presence of intra and inter-observer variability, the fact that hyperechogenicity and even a heterogeneity on ultrasound is an important finding, but is not necessarily specific for the particular manifestation of CF abnormalities. And lastly, a normal ultrasound cannot fully rule out the degree of underlying fibrosis at milder stages. Having said that, the most important development in the last decade in an ongoing study, the PUSH study, hopefully will improve our ability to understand and use ultrasound effectively in persons with CF. The PUSH study, or prediction by ultrasound of the risk of hepatic cirrhosis in CF, has the objective of determining the utility of abdominal ultrasound at baseline, or in this case, in enrollment of the study, to predict the future development of cirrhosis in subjects with CF over a 9-year period. Children aged 3 to 12 years with CF and pancreatic insufficiency have been included, and the primary outcome is the development of cirrhosis, as defined in this case by imaging criteria. The PUSH study seeks to enroll and has been following patients in 4 different categories: those with a heterogeneous echogenicity pattern on the liver, those with normal echogenic pattern on the ultrasound, those with cirrhosis on ultrasound, and those with diffusely homogeneous echogenic pattern on ultrasound, so 4 groups. The initial report from the baseline characteristics found that 82% of patients in a cohort of over 700 children had a normal ultrasound, 8.9% had a heterogeneous ultrasound, homogeneous echogenicity, such as steatosis, was found in 5.7%, and unexpectedly, cirrhosis was detected in 3.3% of patients. More recent studies from the PUSH collaborative have looked at the impact of the baseline ultrasound and also on blood work. In this study, there was an association between the degree of liver abnormalities on ultrasound and elevations of serum ALT found in heterogeneous, nodular, and homogeneous echogenic livers compared to normals, as well as the GGT level, which was increased in these 3 groups with abnormalities compared to those with normal ultrasound findings. Furthermore, the association between the ultrasound findings and markers of portal hypertension was detected, particularly with those with a nodular liver and with their heterogeneous findings having lower platelet counts compared to those with normal ultrasound findings, and those with spleen size adjusted for age, with an increase in this marker for those with nodularity as a surrogate marker for portal hypertension. Lastly, there was an association between ultrasound findings at baseline with calculated scores for portal hypertension, such as the AST to platelet ratio index, or APRI, and FIB4, as shown here, indicating that baseline ultrasound findings had some predictive abilities and correlation with liver enzymes and calculated scores for portal hypertension. Importantly, the ability of certain biomarker variables to even predict these ultrasound findings was further assessed. And I will highlight that those who had a nodular ultrasound versus a normal ultrasound had distinction in the AST to platelet ratio index and GGT, with an area under the receiver operating curve of 0.96, or quite robust. A further study evaluated over 700 pediatric patients who were receiving annual ultrasounds, again, as part of the PUSH collaborative, and patients who had a baseline heterogeneous ultrasound had an over 9-fold increase incidence of eventually developing a nodular pattern in their liver on ultrasound compared to having had a normal ultrasound at baseline. In other words, 23% of those with a baseline heterogeneous liver ultrasound developed nodularity subsequently, versus only 2.6% of patients with a normal finding, highlighting the importance of a baseline assessment in the future risk for these patients. Still, it should be pointed out that over 75% of patients with an initial heterogeneous ultrasound finding did not develop nodularity. And so therefore, the heterogeneous findings on ultrasound cannot be taken as an unequivocal message that nodularity and cirrhosis will develop. it would be more of a risk factor needing further attention. The group of Dr. Sellers at Stanford has done some wonderful work in recent years to help us understand certain cutoffs that might be used to determine when ultrasound should be obtained. In this study, CF patients who are at least 6 years old and who had exocrine pancreatic insufficiency were evaluated with ultrasound. Shear wave elastography is a non-invasive marker of fibrosis, and these were compared to liver enzymes and calculated scores for portal hypertension. First, a group of Dr. Sellers noticed that ultrasound correlates with elastography, non-invasive markers of fibrosis. You can see that those who had a nodular liver on the ultrasound had a significantly increased fibrosis measurement by shear wave elastography compared to those that had echogenic and normal findings. Furthermore, the ultrasound findings, in this case nodularity, correlated with AST, ALT, GGT, and a lower platelet count. Importantly, ultrasound also had a nice correlation with calculated scores for portal hypertension, such as the AST to platelet ratio index, FIB4, and the GGT to platelet ratio. Most importantly, from my perspective, was this very helpful proposed algorithm for when an abdominal ultrasound could be triggered. According to this algorithm proposed, if the GGT is less than 21 and the APRI score is low and not concerning, no ultrasound might be required. On the other hand, a patient with an elevated GGT and a more concerning GGT to platelet ratio perhaps will benefit from abdominal ultrasounds. I think this type of algorithm, which can be further developed for use in adult populations, would hold promise of incorporating not just imaging studies, but the integration with enzymes and calculated scores. How about MRI? A very helpful study from approximately 2 years ago from Europe looked at some of the key features of CF liver abnormalities in adult patients with CF. And this group found that there was 3 independent imaging descriptors that were able to distinguish patients with liver involvement in CF from controls. They included an altered gallbladder morphology in terms of microgallbladder seen in the upper right-hand corner, periportal tracking around the portal tracts, and periportal fat deposition. These markers need to be further studied, but clearly indicate a higher risk of significant liver involvement in persons with CF. We should also highlight that there is a less common but well-described sclerosing cholangitis variant of persons with CF that may occur even in the absence of clear liver test abnormalities. However, if the strictures or narrowings of the bile ducts become significant enough and clinically relevant, that can lead to pruritus, biliary obstruction with jaundice, bacterial cholangitis, and also intrahepatic lithiasis. To evaluate for this manifestation of CF liver involvement, an MRI, and more specifically an MRCP, would be the optimal study. And although less common than the other manifestations of CF liver involvement, it is important to keep in mind the possibility of strictures in this patient population. Now, we should acknowledge that not all liver manifestations in persons with CF are due to CF, and in particular, this may apply to adults. In this study of over 100 adults with cystic fibrosis, about 15% of these patients had steatosis on ultrasound. Risk factors for steatosis were an elevated BMI, higher FEV1, and of these patients, they had a higher ALT compared to those who did not have steatosis. Importantly, there was no increase in cirrhosis, portal hypertension, or any association with pancreatic insufficiency or CF-related diabetes. Therefore, this patient cohort, as you can tell, has a very different phenotype from those with pediatric age pancreatic insufficiency. And in my view, this indicates that the general unfortunate high prevalence of steatosis from metabolic syndrome and non-alcohol related fatty liver is a risk factor that can co-occur in patients with CF, of which we should be aware. We will briefly discuss next the imaging modalities for non-invasive measurement of fibrosis, such as transient elastography or FibroScan, shear wave elastography, which I alluded to recently, and MRI elastography or MRE, which can give a composite value of fibrosis assessment throughout the entire liver. Transient elastography or FibroScan has been shown in a study from the National Institutes of Health of having an association with laboratory parameters of CF-related liver involvement, and in particular, a FibroScan value of greater than 6.8 kilopascals in adults was linked to markers of CFLD, including platelets, AST and ALT, APRI, and FIB4. Furthermore, the combination of stiffness measures, such as with transient elastography with APRI, was able in a more recent study to have a wonderful area under the receiver operating curve of 0.92 in the differentiation of patients with mild stage 0 to 2 fibrosis to more advanced fibrosis, stage 3 to 4. Clearly, what we need to distinguish in this context is those who have more advanced fibrosis. And it did appear that combining these two biomarkers had significant value added. Lastly, it is important to realize that patients who have some degree of liver fibrosis are at risk of increasing fibrosis over time. And in this helpful study from 3 years ago of over 80 children with CF, patients who ended up developing more advanced cystic fibrosis liver involvement had a more rapid progression of stiffness or liver stiffness measurement of 0.94 kilopascals per year compared to those which had a much more mild or modest increase in fibrosis per year, indicating that for those who are at risk, annual measurement of fibrosis with elastography should be considered. MRE may have some advantages compared to other forms of non-invasive measures of fibrosis. However, particularly in pediatrics, it may be difficult due to the requirement for anesthesia. And in this study just published, there seemed to be an excellent correlation between MR elastography and shear wave elastography, indicating that MRE and shear wave elastography are concordant enough that perhaps shear wave, which is linked to ultrasound, could be sufficient for determining the degree of fibrosis. And shear wave elastography had an excellent correlation with clinical labs such as GGT, platelets, and the AST to platelet ratio index. I'll conclude then with some discussions on the future of imaging in CF-associated liver abnormalities. I believe that there is a need to increase the incorporation of baseline screening abdominal ultrasounds in persons with CF, both in pediatrics and in adults. I think there is a need for better coordination of imaging with clinical labs for risk assessment. Some of the composite scores that I had indicated in the preceding slides will be helpful for our risk assessment of patients. Clearly, the use of ultrasound and MRI will remain essential in the diagnosis of CF-associated liver abnormalities. I think there is a need for more routine use of non-invasive measurements of fibrosis in the monitoring of patients over time in order to see who is progressing more rapidly toward more advanced liver disease. And lastly, I think there is a need to further develop and use imaging studies as surrogate markers so that in the future, they can be used to evaluate the effectiveness of therapies that are directed more specifically at addressing CF liver abnormalities. And with that, I will conclude and thank you for your time.
Hello, everyone. I am Suresh Palle, Assistant Professor in Pediatrics at Oklahoma University. I would like to thank the organizing committee for the invitation to speak at this symposium regarding this very interesting topic on vascular causes of portal hypertension in cystic fibrosis population. These are my disclosures, which I think are not relevant to my current presentation. Learning objectives for my talk today are recognize obliterative venopathy as an important cause of non-cirrhotic portal hypertension in cystic fibrosis, understand the pathogenesis, presentation, and diagnostic test abnormalities commonly seen in cystic fibrosis patients with non-cirrhotic portal hypertension, outline an appropriate diagnostic and management approaches in cystic fibrosis patients with non-cirrhotic portal hypertension. First, I will start with the case here. We have an 18-year-old male with cystic fibrosis referred for splenomegaly. Screening labs show low white blood cell count and platelet count. Exam showed enlarged spleen. Labs show mild elevation of liver enzymes, total bilirubin and INR normal. Triphasic CT abdomen showed patent extrahepatic portal vein Portosystemic collaterals were seen, and spleen size was 19 centimeters. Endoscopy showed grade 2 varices. Liver biopsy was performed by intervention radiologists, and they did 2 passes, and it showed no cirrhosis. Hepatic venous pressure gradient was measured at the same time as liver biopsy, and it was 5 millimeters mercury, which is normal. So here we have a scenario where we are seeing portal hypertension in the form of enlarged spleen and varices, preserved synthetic function with normal INR, and no cirrhosis on biopsy and normal flow. So the question is, what is the cause of ongoing liver issues in this young man? Hepatobiliary disease is the third leading cause of death in cystic fibrosis after lung disease and transplant complications. In cystic fibrosis-associated liver disease, cirrhosis is one of the most important manifestations, and it is well known that it causes portal hypertension. Cirrhosis can be focal biliary or multilobular cirrhosis. Interestingly, another important hypothesis for cystic fibrosis-associated liver disease is vascular cause, which has been recognized more and more in recent years, in which portal hypertension may predate the onset of cirrhosis, which we will discuss in detail today. In 2011, Witters et al. Published in Hepatology that in cystic fibrosis-associated liver disease, portal hypertension was out of proportion with the cirrhosis or fibrosis, and as you can see here in histology, all liver biopsies showed portal venopathy in the form of absent portal veins. Hence, they hypothesized an important vascular component involved in CFLD-related portal hypertension. Non-cirrhotic portal hypertension is the common characteristic of many vascular liver disease. We approach vascular liver disorders as prehepatic, hepatic, and post-hepatic, different causes occurring at different sites. As you can see here, intrahepatic causes of non-cirrhotic portal hypertension is divided into pre-sinusoidal, sinusoidal, and post-sinusoidal. And this is where we will focus today, pre-sinusoidal and sinusoidal vascular component. Non-cirrhotic portal hypertension has gone by many names over the years, like nodular regenerative hyperplasia, non-cirrhotic portal fibrosis, obliterative portal venopathy, which we are going to focus a lot today, and recently more standard terminology, which is portosinusoidal vascular disease. It is now believed that these terms represent temporal and spatial heterogeneity of a single condition whose underlying pathogenesis is obliterative portal venopathy. Fundamental concept in non-cirrhotic portal hypertension is that liver does all its chores. Synthetic dysfunction is atypical. In contrast, in cirrhosis, synthetic dysfunction and portal hypertension worsen with progression of cirrhosis. In non-cirrhotic portal hypertension, it is all about the pressures. Non-cirrhotic portal hypertension or obliterative portal venopathy, in simplest definition, is portal hypertension without cirrhosis. It is a hepatic venopathy involving the small and medium branches of the portal vein, resulting in development of portal hypertension. Importantly here, portal pressure is higher and hepatic venous portal gradient is normal or slightly elevated. Patent portal and hepatic veins are noted on imaging. Preserved liver function. In liver histology, as the name implies, no cirrhosis is noted, but we see a very important finding, which is obliterative portal venopathy. Exclusion of chronic liver diseases and other conditions which cause non-cirrhotic portal hypertension is also important. Portal hypertension is the elevation of blood pressure above 5 millimeters of mercury. When the portal pressure gradient is more than 10 millimeters of mercury, complications of portal hypertension are seen. As you can see here in the cartoon on the right, a balloon catheter is introduced through the jugular vein into the vena cava, the heart, which comes out through the hepatic veins. The pressure measurement, which is made with the balloon occluded in hepatic vein, is called wedge hepatic venous pressure, and the pressure measurement with balloon uninflated is called pre-hepatic venous pressure. Hepatic venous pressure gradient, which is HVPG, is the difference of wedge hepatic venous pressure and free hepatic venous pressure. Coming to the most important aspect of our talk today, liver biopsy and its role in helping with the diagnosis of obliterative portal venopathy in cystic fibrosis related liver disease. I highlighted here specific vascular features in explants and in histology. As I mentioned before, portal obliterative venopathy affects primarily small and medium branches of the portal vein. Liposclerosis is a key feature characterized by increased amounts of portal connective tissue around the vessels with irregular wall thickening and narrowing of the vessel lumen, as you can see here in cut sections. In histology sections here, small and medium portal tracts are sclerotic. As you can see here, increased connective tissue around portal veins and later absence of portal veins in histology section. Second key feature is hypervascularization of the portal tract, in which there are additional vascular lumens within the portal tract and periportal abnormal vessels where those additional vascular lumens occur adjacent but outside the portal tract in the liver parenchyma. These are aberrant vessels. Third feature is herniated portal vein, where portal vein has extensions and direct connections with hepatic parenchyma due to thinning of vessel wall. In non-cirrhotic portal hypertension, we may find changes in imaging that could lead us in the right direction. Findings of note here in ultrasound are hyperechoic area adjacent to the larger branches of intrahepatic portal vein. This hyperechoic boundary to it on cross-section probably thought to represent fibrosis around the portal vein, causing reduction in the lumen of the branch of the portal vein, as you can see here. If diagnostic uncertainty after ultrasound, one can obtain CT scan. As shown here, liver is somewhat shrunken but has smooth contour to it, and there's clear evidence of portosystemic collaterals and significant splenomegaly as seen here. We may also see this interesting change in portal vein morphology from which the term obliterative portal venopathy comes, where main branches of the portal veins seem to be dilated and there's a clear step down in caliber of the branches of the portal vein. Dr. Wetters et al. Published another paper in Journal of Cystic Fibrosis in 2017. They studied 8 patients with CFLD, portal hypertension, who underwent liver transplant. Half of them had HVPG measurements done, which were clearly below the cutoff for clinically significant portal hypertension. 5 out of 8 explants with portal hypertension showed no cirrhosis, but noted to have mild to moderate fibrosis. Obliterative venopathy was evident in all tissue samples. Hence, they proposed again, in at least a subset of CFLD patients, portal hypertension is not due to biliary cirrhosis, but corresponds to vascular change as in non-cirrhotic portal hypertension. This is the paper published in Liver Transplantation Journal from France. As you can see here, this is a single center review over 6 years time period. 10 adult patients who underwent liver transplant for CFLD with portal hypertension. 8 had non-cirrhotic portal hypertension with grade 2 to 3 fibrosis and diffuse obliterative portal venopathy. Only 2 had biliary cirrhosis. Hypercoagulable workup was done in 7 patients and it was normal. Main portal vein was dilated and painted in all patients. Almost all of the explant biopsies showed abnormal intrahepatic portal vein in the form of thrombosis, caliber reduction, and or non-visibility of portal vein. In the same paper here, I will highlight some of the key features. As you can see here, mural wall calcification of the portal vein, in addition to the portal hypertension, as you can see here, huge spleen. This panel shows portal face CT showing disproportionate reduction in caliber of segmental portal branches compared to dilated main portal branches. Gross aspect of native liver here showing a smooth liver surface, but on cut section, it shows diffuse nodular regenerative changes. Last panel here showing absence of small portal vein with interlobular ducts in this portal tract. This paper by Dr. Wu et al. Was published recently from United States. They looked at explants of CFLD-related portal hypertension. 17 CF patients were studied. This is a good number. This is around 15% of CF liver transplant population in United States as per UNOS data. Median age of transplant was 15 years. Key paper in this paper is that none of the explants showed bile duct cystic dilatation or luminal inspissated material showing lack of biliary cirrhosis, even in pediatric cystic fibrosis population. Coming to pathogenesis of obliterative portal venopathy in cystic fibrosis, most of it is speculative. It could be hematological, where there is thrombosis of distal portal branches as a result of platelet activation. Could be immunological. CF is associated with with a rise in markers of vasculitis and primary endothelialitis that could favor portal venous thrombosis. Prothrombotic state. In a recent study involving more than 100 patients with CF, thrombophilia abnormalities or hypercoagulability were found in 50% of the cohort. Repeated pulmonary and intestinal infections, especially with E. coli, might cause recurrent septic embolization and subsequent obstruction of small portal veins. In fact, there are animal models where they inject E. coli into the portal vein repeatedly to create non-cirrhotic portal hypertension. Small intestinal bacterial overgrowth causes translocation of bacteria and release of pro-inflammatory cytokines that enter the liver through the portal circulation. Finally, CFTR is expressed in vascular smooth muscles and is responsible for vascular relaxation, similar to other chloride channels in smooth muscle. Could lack of CFTR cause increased vascular tone or narrowing of the vasculature, especially in the liver, especially the portal vein? We don't know the answers to this question. Ivacaftor has been shown to reduce vascular tone in major arteries, but we don't know the effects of these modulators in liver vasculature. This is an illustration regarding pathogenic mechanisms involved in the development of vasculitis in CF. Deficiency or impaired function of CFTR leads to intracellular ionic alterations and immune cell activation that can trigger cascade of events like inflammasome activation, release of pro-inflammatory cytokines, induced netosis, and production of ANCA antibodies and immune complexes deposition, finally resulting in vasculitis along with increased release of interleukin-8 by endothelial cells. Coming to the management of non-cirrhotic portal hypertension. Management and physiology of cirrhotic-related portal hypertension and non-cirrhotic portal hypertension are intermittently linked. While a lot of principles are derived from management of cirrhosis or study of cirrhosis, non-cirrhotic portal hypertension parallels but not overlap cirrhosis. Non-cirrhotic portal hypertension clinical manifestations differ from cirrhotic portal hypertension. Hypersplenism and cytopenias are more common in non-cirrhotic portal hypertension and typically more severe, giving rise to the need for spleen guard in children. Synthetic function is normal in non-cirrhotic portal hypertension. HPPG is normal or slightly elevated. Unlike in cirrhosis, it is usually high. Varices are common in both, but variceal bleeding is typically presenting feature in non-cirrhotic portal hypertension. Ascites is less common in non-cirrhotic portal hypertension. Encephalopathy is present, may not be severe, and often subclinical. Screening for signs of portal hypertension like varices is important. Also, monitoring for complications of portal hypertension, especially hepatopulmonary, portopulmonary, and portal vein thrombosis should be done. Portal hypertension and advanced liver disease management will be discussed separately by my colleague Dr. Freeman in this symposium. Transjugular intrahepatic portosystemic shunt, also known as TIPS, has been used for uncontrolled or recurrent variceal bleeding and refractory ascites. Splenectomy or partial splenic embolization can increase platelet count, but benefits have not been demonstrated to outweigh risks, especially in CF population. Liver transplantation data is scarce and survival is favorable. Indication for liver transplantation are decompensation or uncontrolled variceal bleeding, ascites, hepatic encephalopathy, hepatopulmonary syndrome, progressive liver failure with synthetic dysfunction, or as part of combined lung and liver transplant. One should remember that MELD scores are low non-cirrhotic portal hypertension that affects prioritization for liver transplantation. Conclusions. One of the problems in obliterative portal venopathy or non-cirrhotic portal hypertension is positive of prospective literature to make any evidence-based recommendations. As synthetic function is normal, traditional prognostic markers in cirrhosis, including MELD and Child-Pugh scores, are not predictive of outcomes. No diagnostic gold standard tests or no accepted staging system. As we all know, staging is an important concept of any disease, but here traditional markers like albumin and PT don't work, or they're typically normal. It is possible to see evolving disease patterns in a single patient. One might see vascular changes followed by regenerative changes and eventually fibrotic changes in same patient over the time. Obliterative portal venopathy is a rare manifestation of CF disease, making it difficult to study and manage. Complicating this is that in genetic diseases like CF, there are multiple phenotypes coming from a single genotype, and there are multiple genotypes that can give rise to single phenotype. Patients are also living longer, and this gives more time to develop liver-related complications. Key takeaways today are in cystic fibrosis-associated liver disease, non-cirrhotic portal hypertension is a consequence of obliterative portal venopathy. CFLD has a multi-factor etiology. Non-cirrhotic portal hypertension needs high index of suspicion with manifestation of portal hypertension in the absence of liver stiffness or elevated HVPG. As I mentioned before, there is near universal disagreement on nomenclature. It doesn't matter exactly what we call it for the individual patient if we understand it and seek expert help, especially pathologists in this scenario. Non-invasive monitoring of disease progression is challenging, but evaluation of platelet count and spleen size may be helpful. There are no medical therapies that prevent disease progression. For more advanced cystic fibrosis-related portal hypertension, portosystemic shunting procedures to alleviate portal hypertension might be preferable over liver transplantation. Thank you very much for your attention.
Thank you to our chairs and the NACFC committee for inviting me to talk today. It is my pleasure to be able to discuss advanced liver disease and CF and how it is managed. I do have some pertinent disclosures, including some work that we will review today that was funded by the Cystic Fibrosis Foundation and the NIH that I was a part of. I do have some other disclosures that are not pertinent to the information we will cover today. So our objectives is really to start by defining advanced hepatobiliary involvement in cystic fibrosis. Please note that we did not use the term CFLD or cystic fibrosis-associated liver disease. I will touch a little bit more on that in the next slide. We will discuss monitoring approaches for advanced liver involvement in cystic fibrosis. And of course, where I think the majority of the talk will be focused on is the treatment options for liver involvement in CF. So what is CFLD, CF-associated liver disease? Well, for many of us, this has just been a bucket term used to describe a broad phenotype of liver involvement in cystic fibrosis. This ranges from cirrhosis and portal hypertension down all the way to minor and likely clinically insignificant or of little significant elevation in transaminase levels. For today's talk, though, this is really what we're focusing on. These patients that have cirrhotic macronodular livers, portal hypertension with these big portal veins and enlarged spleen. And this is where we will focus today. So what is advanced hepatobiliary involvement in CF? Well, really it's the 5 to 10% of patients that develop portal hypertension and or cirrhosis. And the order of portal hypertension and cirrhosis is there on purpose. For many other forms of liver disease, we think of cirrhosis first within the development of portal hypertension. But as we learned from Dr. Paye in his talk, we do know that non-cirrhotic portal hypertension is an important consideration in cystic fibrosis and one we must consider. Advanced liver involvement happens almost exclusively in children, as evident by this graph here. We can see that for the majority of patients, really around 10 to 12 years of age is the median time of presentation. And we know that the clinical outcomes of having liver involvement are very important. So in this study by the CFLD network, they looked at patients that developed cirrhosis and then the 10 years after that diagnosis, and showed that roughly only around 5% of patients went on to have varicose bleeding, which was maybe a little bit lower than expected. Around 6 to 7% went on to needing liver transplant within that 10-year period. Death from liver disease was again around 6%, but I think the most important and striking thing is if you look at the estimated cumulative incidence of all-cause mortality, reached nearly 40% in that 10 years after the diagnosis of cirrhosis. And this data is mirrored by a Dutch population study that really looked at cumulative survival amongst controls versus those with CF-associated cirrhosis, and showed that survival was about 14% lower for all-cause mortality amongst those that had cirrhosis or advanced liver disease. So it's not just the liver that seems to be involved, but it really does seem to cause or be an independent risk factor for long-term mortality. So with that kind of in mind, here's probably a very familiar case that most, if not all of us, have encountered some version of. So this would be a 14-year-old female, plus or minus a couple years, could be male, who comes to the hospital for a pulmonary exacerbation. Let's say the resident or medical student goes in and they get a little bit of a history of abdominal pain. They go back and look at the labs, ensure that the AST, ALT have been mildly elevated, should be 30 or less for the most part. GGT cutoff is usually somewhere around 20 to 30, depending on the lab. And so you see all three of these liver markers being mildly elevated. And so the knee-jerk reaction is to get an ultrasound, and we get this. We get this sort of nodular, non-smooth appearing abnormal heterogeneity and a radiology read of cirrhotic liver in a patient who had never had any liver disease. And it can be a very striking diagnosis for the provider and the patient, as you can imagine. So how do we prevent those type of things from happening? And the thing we get asked, obviously, is how do we monitor? And blood work is the first thing that comes up. I'm showing two studies here, but there's a number that show a very similar story. On the left, you see violin plots from our group in the PUSH study that looked at patients that had a normal ultrasound pattern here in this kind of bluish color, a heterogeneous pattern in this green, nodular in purple, and homogeneous in this reddish color, and looked to see if there was differences in their conventional hepatic biomarkers. And so here you can see ALT, GGT are statistically significantly higher than those with a normal pattern. But look at the levels. The ALT is only around 50 or 60. GGT, again, only around 60. These are not large elevations from baseline. Similarly, we see decreased platelet levels amongst those in a nodular pattern. Median level still around 250, a completely normal number. Spleen size Z-score a little bit more abnormal amongst nods. We look at APRI and FIB4 with those definitions below for those that are less familiar with these. Again, mild elevation amongst the nod group, but with broad variation and lots of overlap. One of the hallmark studies done from the group from the Netherlands really looked at cutoff values for GGT as being a marker. And they showed that a very mild GGT elevation of 35 had an area under the curve of 0.9 for patients with advanced liver disease. Again, remember that cutoff is usually somewhere between 20 and 30 based off your lab, so maybe less than 1.5 times the upper level of normal. They went on to look at sensitivity and specificity, and here again in the blue bar, you see this value of 35 being highly specific, but very poor sensitivity. So amongst those that developed advanced liver disease, if you go back and look, they almost all have elevation and persistent elevation of their GGT. There's also a large number that have high GGTs that don't seem to go on to have advanced liver disease. So the other question is, well, should we just get imaging on everybody? Surely that predicts. And so recently from the PUSH study, we did publish our interim analysis with the main focus being those patients that had a heterogeneous ultrasound pattern and do they go on to develop a nodular pattern. So in our cohort, followed over about 4.5 years, we had 55 patients with a baseline heterogeneous pattern, of which 13 or almost 24% went on to have a nodular pattern at most recent follow-up. Amongst the normals, there was only 3% or a little bit less that went on to have a nodular pattern, showing a relative risk of about 9 for the development of a nodular ultrasound pattern amongst those with a heterogeneous ultrasound at baseline. But remember, that means there's roughly 75% of patients that had that pattern that did not go on to have a nodular pattern as essentially a surrogate of having advanced liver involvement. We also looked at the area under the curve. Here in the red line, shows if we look at just the ultrasound pattern, heterogeneous as a risk for developing nodular versus having an elevated APRI in the blue line. I'm sorry, my cursor is not working. Here we are. And you can see that there's not a big difference between the two. In the study on the right, which is a combination of the group out of Australia, Peter Lewington and Grant Ram, with Daniel Leung and his group in Houston, they looked at controls with those that had no liver disease and those with CF liver disease that had biopsies, and looking at the liver stiffness as measured by vibration-controlled transient elastography or FibroScan. And as you can see, those patients that had liver disease and higher METAVIR stage by biopsy had higher liver stiffness. They then looked at their area under the curve with a cutoff value of 5.5 kilopascals, as noted above, and showed an area under the curve for liver stiffness of around 0.8. If they looked at just APRI, it was lower at 0.66. But I think the story that you really see is when you combine the two modalities, you get to an area under the curve of closer to 0.9. So having an elevated APRI and elevated liver stiffness by a VCTE really seemed to predict those patients that had higher METAVIR scores or more advanced liver disease. I think this is brought home nicely by this study from the group out of Germany that did a single center experience of 23 patients that developed advanced liver disease and needed a transplant over a 15-year period. And they looked at these Venn diagrams to see if these patients had overlap in conventional liver markers, here ALT, alkaline phosphatase, and GGT. And you can see there's only 6 patients that really had elevation in all 3 of those. They then looked at ultrasound scores, these are Williams scores, and whether they're elevated as their marker. And 8 did show that they had elevation in their shear wave elastography by ultrasound, as well as vibration-controlled transient elastography. If you increase that threshold of that Williams score, made it a little bit more difficult. There was only 6 patients who ended up sort of being in the center of that Venn diagram. And most importantly, of those patients that had 2 abnormalities on labs and 2 abnormalities on imaging, all 8 of those patients did show up right in the center of those Venn diagram, really hammering home the point that it's probably not just labs and probably just imaging. It probably is some combination of the two to really try to identify those patients as early as possible that will have advanced liver involvement. So the obvious question is what is the plan? How do you do this? And I don't know what the perfect plan is. I just think you need to have one. So here's 2 that have been proposed. The one on the left was from Dominique Debray and the group in France, really published about 10 years ago. Things haven't changed greatly. Really looking at those annual labs, using your physical exam, then going to imaging, and the deciding if advanced workup is required. Our moderator, Zach Sellers, and his group at Stanford did something very similar, but really, after a lot of data I'm not showing you, really looked at a GGT cutoff as 21 as being their first marker. Again, upper level of normal may be only 20 or even higher than that, depending on your labs. It's a very low cutoff. And then using APRI and GGT to platelet ratio to decide if ultrasound is needed, and then advanced workup from there as indicated by the hepatologist. So this really is important to have somebody who knows the nuances of these labs and these imaging to help you in caring for these patients and for monitoring them. So with that being said, we'll get into the meat of this for the last half of the talk, which is really talking about the management, specifically focusing on Actigol or ursodeoxycholic acid, shunts and surgery procedures, transplant, and then the effect of our modulator therapies. I believe any talk really has to start with ursodeoxycholic acid. There's lots of patients who I see that get transferred to me or come for second opinion. They've been started on Actigol. There's plenty of centers that as soon as transaminase levels increase, they get started on Actigol. And that's essentially what this study looks at. So this was the ursodeoxycholic acid study group out of Europe, multiple countries involved. And they basically divided centers into high prescribers of urso versus those that were low and looked at their outcomes. And here specifically, we're looking at the proportion with portal hypertension and those that had deaths in the absence of portal hypertension. The darker line is those that were high prescribers of urso, with the dotted line being low. And as you can see, there was no statistical difference in those with portal hypertension, maybe even higher in those that were on higher urso or centers that had higher urso rates of prescribing, and absolutely no difference in deaths in the absence of portal hypertension. And this table over here really drives home that point that if you separate it into those 2 types of prescribing centers, there is no difference in portal hypertension, wait list for liver transplant, indication or need, for liver transplant, deaths from liver disease, deaths from pulmonary disease, or all-cause mortality. This very much matches the most recent Cochrane review, which came out in 2017. They finally said they're not going to continue to publish it, but over and over they have shown that ursodeoxycholic acid does not seem to change hepatocellular enzyme levels, nutritional status, need for transplant, mortality, even biliary excretion or development of portal hypertension. So at least at this time, unless a bilirubin, a direct bilirubin is elevated, there's really no clear indication for ursodeoxycholic acid. An intervention that people may be a little bit less familiar with would be a partial splenectomy. This is an experience from the group in Lyon, France, that looked at 19 patients that had signs of portal hypertension and abdominal pain who underwent partial splenectomy. The idea being less complications compared to a total splenectomy, and you do have some splenic function to protect you from encapsulated organisms. In this series of the 19 patients, you can see that over around 8-year median follow-up, 4 went on to die, 3 went on to have significant GI bleeding. Portal hypertension was still prevalent in about 5 patients with hypersplenism and splenomegaly still present. Interesting, 5 went on to have hepatic insufficiency, which is relatively uncommon in patients with CF and advanced liver disease. And maybe most striking, 13 of the 19 at follow-up still had grade 2 or higher varices. So given the modest clinical improvement with possible big side effects, not surprising this hasn't caught on. Somewhat similarly is this experience out of Australia where they looked at patients who underwent splenectomy, total splenectomy without any other shunt procedure. So of their 650 patients, there were 9 that underwent this procedure. Their mean age of presentation was about 8, with splenectomy occurring around 15 years of age, and mean follow-up over 6 years. You can see the indications ranging from typical signs of portal hypertension like low platelets to all the way down to actually impaired lung function. But the idea is this a big spleen pushing up on the diaphragm and somehow limiting your lung capacity? And so what they were able to show was over a 2-year period, you did see this improvement in lung function. Unfortunately, there's not further follow-up. And we did see a similar pattern after liver transplant in patients that really seemed to disappear after around 3 years. So hard to say. I think knowing that there wasn't a ton of improvement, there is very significant side effects with having a total splenectomy, lots of surgical complications in addition to your loss of encapsulated organism coverage, that again, it's not surprising this hasn't caught on more. An area that has gained a lot more attention and focus is the idea of a distal splenorenal shunt. So the group out of Lurie Children's in Chicago has taken the approach that if patients have grade 3 or 4 varices with no signs of synthetic dysfunction, that they will use the splenorenal shunt. And if they have any signs of synthetic dysfunction, they'll go on to liver transplant. So during this period, 5 patients were followed over around 4.5 years. None went on to need liver transplant. 1 did go on to have a death related to pulmonary disease, and 1 had a mild complication, if you will, 2 years afterwards of an extrinsic compression of their left renal vein. Failed angioplasty, but the patient clinically did well. Importantly, you can see pulmonary function before or after the procedure did not change. There was signs that portal hypertension got better, including decreased spleen size. There was no impact on growth parameters or any of your other biological markers of liver disease, if you will. So therefore, given this seems to work pretty well, doesn't have nearly as many side effects, it's not surprising that this is gaining more attention and focus. For many, though, I think that they believe that liver transplant is really the cure, if you will, the main intervention for patients with advanced liver disease. I'm frequently asked, what are the main indications? And I really think for CF, it's really these complications of portal hypertension we've been discussing. It's if you can show poor growth nutrition that really seems to be impacted by their liver disease. Importantly, though, I think there's contraindications such as uncontrolled CF-related diabetes, which can be also a bit of an argument with some centers now doing in-block liver pancreas. It may not be a contraindication. And I think the other one we really have to think about in CF is those that have NTM, cepacia, some of these other more dangerous bugs that are harder to eradicate. And in these cases, it's extremely important to work with a knowledgeable infectious disease expert. So why do we think of transplant? Well, generally these patients do well. So this is some old data from 10, 12 years ago, looking at CF compared to other liver transplant outcomes. And in adults, the blue line being cystic fibrosis, we do see that these patients do much worse. But if we do perform transplant during the pediatric age, they typically do a little bit worse, but relatively about the same as our other indications for transplant, with survival around 85% at 5 years. We also showed in one of our reviews of UNOS data that as we get closer to our new eras in medicine, that we do see survival continue to improve, Possibly that is due to our improvement in CF care, but more likely improvements in transplant care. Most recently was the study of a group in Cleveland that looked at patients who had needed a transplant within their group and those controls, and really showed that within about 60 months after transplant, hemoglobin, white blood cell count, and platelets all seemed to normalize, while there was no changes in their nutritional markers, spleen Z-score, and FEV1 remained maintained. And if they looked at their survival probability out to age 40, there was really no difference. The idea here, it shows to me that if you can give them a new liver, you can really get them back on par with their peers, and outcomes should be expected to be the same. Final area of interest, I think, is what is the impact of modulators on liver involvement? In the top table, we're actually showing a group. This is actually the group out of Cleveland. I apologize. Looking at patients who are on ivacaftor or lumacaftor and whether they had changes in steatosis or other biological markers. Here you can see of the 9 patients who were on modulators, they had significantly less fat fraction compared to those that weren't. However, the reference range is less than 5, so really in both groups, they did not have significant steatosis. You also see some mild improvement in alkaline phosphatase, but those were about the only changes we saw in this cohort. In the bottom is a group out of France who looked at patients, 4 of which who had multinodular liver involvement, and then 19 that did not. And looking at their conventional hepatic markers, you see decreases in GGT, ALT, AST, and bilirubin of those patients, again, on lumacaftor and ivacaftor, no changes in the other markers. And also of note, within the PUSH study, in a paper that will be coming out soon, we did show that only 1 patient or 2% of those patients that had a nodular ultrasound pattern or presumed advanced liver disease had been on any modulator therapy. Could be a variety, highly effective, or stuff like lumacaftor, ivacaftor, whereas 14% in the normal group had been on modulator therapies. Again, can't make a lot of it, but it's something to note to give us some signal that these medications may be giving us some hepatic improvement or benefit. So in conclusion, we do know that advanced liver involvement in CF continues to represent a source of morbidity and mortality. We do need better screening. We do need better ways to make sure we pick up these patients early. I think the conversation between systemic shunt procedures and transplant remains pertinent and important. I think that discussion will go on. And really what the impact of modulator therapies is going to be remains unknown. I know it'll be several days till I get to answer questions after recording this, but I do look forward to hearing from everybody. I hope you've enjoyed the conference, and thank you for the opportunity.
Hello, my name is Vanya Casper, and I will be speaking today on CFTR modulators and liver function tests. I'd like to say thank you to the CF Foundation for giving me the opportunity to speak today, and to the Digest mentors who have taught me so much over the last 2 years. I have no relationships to disclose related to this presentation. The objectives are, at the end of the presentation, the participant will be able to analyze pre-treatment liver function test results, discuss the frequency of abnormal liver function tests in cystic fibrosis at baseline and with different CFTR modulator therapies, plan additional hepatology workup or referral, and plan medication initiation and cessation. I'd like to start with the case of HS. She is a 12-year-old female with F508del heterozygous mutation. She is a healthy child with a BMI at the 68th percentile and an FEV1 107% of predicted. She is starting elexacaftor, tezacaftor, ivacaftor, from which point I will refer to as Alex-Tez-Iva. In anticipation of this, she had labs drawn, and her AST was mildly elevated at 39. Her ALT was elevated over 2 times the upper limit of normal at 91. Her GGT and bilirubin were normal, and so she was referred to hepatology for further evaluation. And so some questions come up for her. How common are liver function test abnormalities at baseline in cystic fibrosis? How should she be evaluated? Can we start CFTR modulators safely? And when do we decide, if we need to stop therapy? So some basics on liver function tests. The hepatic function panel is actually a misnomer because many of the tests don't tell us anything about the function of the liver. AST and ALT tell us about hepatocyte inflammation, and notably ALT is generally more liver specific. AST elevations can also be caused by muscle inflammation and hemolysis. Albumin, glucose, and INR are truly the function tests that tell us whether or not the liver is working. Alkaline phosphatase and GGT tell us about biliary damage. And then bilirubin tells us about hemolysis, hepatocyte transport, and excretion. The question of what a normal ALT is was looked at by Schwimmer and colleagues, and they looked at the normal upper limit of normal in 43 children's hospitals in the United States. They found the mean was 53 with a very wide range of 30 to 90 international units per liter. Then they looked at the NHANES database and found that at the 95th percentile for healthy weight, boys had an ALT value of 26 and girls of 23. So this means that many of the labs across the country use ALT cutoffs that are far above what we should be accepting as normal. And we are missing liver inflammation if we are not actually looking at lower values for upper limit of normal. This is also true for AST and GGT, which are often inflated as well. LFT abnormalities in cystic fibrosis are very common at baseline. In a study by Woodruff et al. Looking at annual visits of patients, about 100% of those patients had at least one elevated liver function test by the age of 21. 93% of those being ALT, 63 AST, and GGT elevations in 39%. Only 85% of these had persistent elevation over 6 months, which is more significant. Of all of these LFT elevations, only 5 to 10% of patients will progress to have multilobular cirrhosis. And GGT has been shown to predict progression to multilobular cirrhosis. This study by Meyer-Hamlet looked at 3 completed randomized control trials of medications used to treat Pseudomonas. They included 376 patients with a mean age of 14 years and 8.3 months of follow-up. Of the patients who had normal liver function tests at baseline, 25% had new onset of increased LFT value. This was more likely to happen if they were over 18 years of age, and the majority had no significant hepatobiliary disease, and the majority were also of an unknown etiology. Importantly, only 13% of these were deemed to be clinically significant. CFTR modulators have been shown to have both positive and negative effects on the liver. I think it's important to step back and remind everyone about where the CFTR protein is located in the liver and the bile ducts. In this diagram, the hepatocytes are represented by green squares. The blue oval in the middle is a biliary ductule, and the blue cylinder is a bile duct, which is lined with cholangiocytes. The CFTR protein is located here in the wall of the bile duct. It is also named ABCC7. Within the hepatocytes, there are other protein transporters, and they have similar names, some of them, to the CFTR, and similar structures. Ivacaftor has been shown to affect 2 of these proteins, ABCB11 and ABCB4, and improve their transport. So when we use CFTR modulators, we are not only improving the function of the CFTR protein, but other transport proteins within the liver. And as follows, we see that there are more studies coming out that discuss improvements in liver function tests. Dempsey et al. Showed that 86% of the patients that they treated with lumacaftor ivacaftor had LFT improvement, and 100% of the ones on ivacaftor alone, albeit this was a very small study. Bile acid homeostasis was improved in a study by Van de Peppel and colleagues with ivacaftor. Hepatic steatosis and cholesterol metabolism were shown to be improved with both in 2 studies with lumacaftor and ivacaftor. I'd like to focus on this recent study by Drummond et al. Looking at 28 patients treated with ivacaftor lumacaftor. They were homozygous F508del mutations, and there were 4 patients who had multinodular liver disease and portal hypertension. 19 of the patients had some other CF abnormality, either serologic or radiologic, and 5 had no liver involvement at all. They were evaluated with liver function tests, ultrasound, and protein density fat fraction, and their results showed no hepatic adverse events, no episodes of liver failure, and importantly, all AST, ALT, and GGT all decreased through the course of the study. This is a diagram from their study showing AST, ALT, GGT, and bilirubin. The first columns represent a 12-month pre-treatment value. The second bar represents the value at the time of initiation of treatment, 6 months and 12 months post-treatment. And it is clear that all of these parameters improved on treatment. I'd like to mention that our very own Zach Sellers is presenting his data on a similar study looking at treatment with tezacaftor ivacaftor and lumacaftor ivacaftor and non-invasive parameters later this afternoon. However, unfortunately, we have some evidence that there is damage in the liver. This study is the first study to be published about a drug-induced liver injury from Elex-Tez-Iva. This was a 21-year-old female with F508del heterozygous mutation. She had no known liver disease at baseline based on her labs and her non-invasive liver markers of fibrosis. She was started on Elex-Tez-Iva and at 5 months noted to have significant elevation in her AST and ALT. And 2 weeks later, when labs were repeated, she again had a significant jump. So the medication was stopped. The labs fell 2 weeks later, but unfortunately, at 1 month after stopping Elex-Tez-Iva, her labs again rose very significantly, and her bilirubin rose to 3.1. Her liver inflammation did peak at day 36 after stopping the medication, and all of her testing, imaging, and serologies were negative for other etiologies of hepatitis. There was a concern at one point about herpes virus, but this was, and acyclovir was started, but this was stopped when stain on histology was negative. Her liver biopsy was consistent with a drug-induced liver injury. And so this leaves us with the question of in a patient like this, how do we decide whether or not to restart? And that has to be a careful and very individualized discussion about the risk and benefit for that particular patient. So thinking about our evaluation, our differential starts with infectious hepatitis, including the hepatitis viruses, EBV and CMV. drug-induced liver injury, which is very common for our patients, as antibiotics are the leading drug involved in drug-induced liver injury cases, essential fatty acid and carnitine deficiency, alpha-1 antitrypsin deficiency in heterozygous states, Wilson's disease, hemochromatosis, non-alcoholic fatty liver disease and NASH, autoimmune hepatitis, and celiac disease. I'd like to take a second to talk about the Child-Pugh score because it is mentioned in the prescribing information for these medications. This is a prognostic score of chronic liver disease, and it includes the bilirubin, albumin, protime, ascites, the presence or absence of ascites, and hepatic encephalopathy. These factors are added together, given a score, and then divided into classes with estimates of 1 and 2 year survival. You can see that class A has a very good survival rate corresponding with mild liver disease, and C has a very poor survival rates indicating very severe liver disease. It is important to note that most of our patients with CF who have liver involvement fall into a Child-Pugh class A. Prescribing information for both ivacaftor and ivacaftor-lumacaftor have dose reductions for class B and class C, meaning that a child with Child-Pugh A should be able to start the medication at a normal dosing. Elextez-iva has a dose reduction for Child-Pugh B and recommends not to use the medication in Child-Pugh C. This table shows the frequency of liver function test abnormalities from the placebo-controlled trials for all of these medications. And you can see that all of them have a small percentage of patients who do have liver function test abnormalities, sometimes up to 8 times over the upper limit of normal. Only Elextez-iva had bilirubin increased in the placebo-controlled trials and in the prescriber information, although bilirubin elevations have been seen with the other medications as well. So it is notable to discontinue the medication if your AST and ALT rise above 5 times the upper limit of normal after starting, or if your AST and ALT rise 3 times above the upper limit of normal with a total bilirubin increase over 2 grams per deciliter. Then you need to monitor for complete resolution of the abnormality and return to baseline and assess whether restarting is indicated in that particular case. Going back to HS, her screening labs were negative. Her ultrasound showed an echogenic liver with normal Doppler and elastography. Elextez-iva were started at standard dosing because she was a Child-Pugh A, with a plan to recheck labs weekly for the first month. These were her pre-treatment labs. At 1 week, she did have a slight bump and her GGT increased slightly, so ursodiol was started. Repeat labs showed that she had responded to the ursodiol and, or perhaps even to the Elextez-iva. And, but unfortunately, we needed to stop because she had developed a new migratory rash. Our plan was to restart Elextez-iva if her LFTs remained stable and her rash improved. This did occur, and I unfortunately don't have an update because that just happened. So to summarize, abnormal liver function tests are very common in patients with CF and do not always indicate significant liver disease or that the patient will have significant liver disease. Liver function tests over 2 times the upper limit of normal should be evaluated further with your GI or hepatology colleagues. After starting a CFTR modulator, it is important to monitor the liver function closely because things can change. And it is important to keep an eye on patients who have a baseline indication of liver dysfunction. CFTRs, modulators, have been shown that they may actually improve liver function and fibrosis, and there are rare cases of serious adverse liver events. And as these medications, we have more experience with these medications, I anticipate that we will have many more studies and case reports published. Thank you very much for your time. And this is Nibbles Woodaway, who says hello and stay safe from Rhode Island.
I'd like to thank everyone who's joined us for this wonderful symposium that we've had today. And a special thank you to our speakers and for their talks that were both informative and enlightening. We've had a number of questions that have been submitted throughout the talks, some of which have been answered and others that haven't yet. So we're going to embark on this live Q&A session. Continue to submit your questions, and I will be relaying these to our speakers, and anticipate we'll have a very lively discussion time now. So let's kick us off. David, I have a question for you. The question was, if you were to obtain baseline ultrasound studies, at what age would this be best done? And Jay, you may also be able to comment after David based on your experience in this.
Really, really great question. Important for screening, also one for which we don't have perfect data or guideline consensus as of yet. But I think that since the majority of the liver involvement in cystic fibrosis, at least in the pediatric range, and I'll of course defer to Jay further, but occurs in the teenage years, it makes sense to have a baseline screening done prior to that. I would imagine in the 6 to 8 year range. But as a non-pediatrician, I really should defer to some colleagues on that. I think for the adult perspective, what I feel very strongly about is that even those who escape, so to speak, any of the more severe involvement from cystic fibrosis liver complications in the teenage years should nonetheless still have a baseline ultrasound, if not previously done in the early adult years, maybe in the range of 20 to 25 years of age. I do think that in the decades to come, we're going to learn a lot more about some of the complications in adult patients, and I would feel more comfortable having that as a baseline in the early adulthood.
Yeah, so I will say that my threshold is low, regardless of year or age. So I know many people have advocated even for making it like your annual labs, once a year you get blood work, once a year you get ultrasound. I definitely don't think there's data to support that. But as we've shown in a couple of the different slides by a couple of the different speakers, the stuff that Zach himself has put out, having some algorithm or some approach, some standardized method that you and your center can use, I think is important. It's not going to be just imaging, as I've said. It's not going to be just labs. It is some combination of all of this. And so just having those early screening mechanisms in place, I get ultrasounds on 2-year-olds and 3-year-olds and 4-year-olds that have elevated transaminase levels because I want that baseline. I want to make sure that I'm not missing something, but it doesn't mean that they get an ultrasound every year either. We then continue to combine with the labs, and we just have a good approach so that we feel as safe as we possibly can. I know it's not a concrete answer, but that's kind of the approach that we use.
Yeah, so I think consensus, if there is to really use your labs as an impetus to obtain the ultrasounds, and then if there's any other concerns for liver involvement, then having a low threshold for an ultrasound. But I think there's a lot of discussion going on as to whether there's some formulaic, just like we get annual labs doing it without even having a pretest probability. So I think more on that, but great questions. Okay, next question is for Suresh. Any suggestions for prevention or worsening of venopathies?
So that's a good question. And again, I don't know the complete answer to it. At this point, again, as everything is speculative, all the pathogenesis related to obliterative portal venopathy in CF is speculative, as I mentioned. And one of the most important thing is vasculitis. And there's different triggers for vasculitis, especially recurrent infections, E. coli. And then again, as I mentioned, CFTR is also expressed, as you pointed out to me many times, Zach, in smooth muscle vasculature also. So there has been some data on modulators improving the smooth muscle tone in arteries, but not much of data in these veins or portal venules. So we have to see. At this point, I don't see any other than monitoring for the complications of obliterative venopathy. There's nothing preventive strategies or anything at this point.
Thank you.
Does someone has any other thoughts?
There's not so much of a question. Someone posted asking for opinion on Trikafta in liver cirrhosis with no liver failure and no symptoms and normal ALT, but hypersplenism. I guess I'll sort of make this a little bit more broad, and Vanya and then others I think can also comment. I think certainly there's a lot of interest in use of Trikafta. We get a lot of questions about should we be using it for those who may have some liver involvement but don't have significant lung disease, and in what scenario, and Vanya, you commented in your talk about what scenarios we might use that. But does anyone want to make any particular comments on the use of Trikafta and those that may have some cirrhosis, but otherwise normal synthetic function, and maybe some portal hypertension? I'll start with you, Vanya, and then open it up to the group.
Sure. So my talk was recorded right before the prescribing guidelines were changed for Trikafta last month. So it is with a recent case of hepatic failure leading to liver transplant. I think that we are gaining more information as Trikafta is used more and more about the potential for significant deterioration on the medication. However, as other studies have shown, that there are patients who have nodular liver disease that are able to tolerate the medication and actually have improvement in their liver function. So I think the benefit, looking at the whole patient as a whole and looking at their baseline lung disease, and trying to make weigh all of these factors, not only the liver disease, but the lung disease, and whether there is the benefit of using Trikafta would work, is it worth it in these situations? And then making sure that if you do go ahead and decide to use the medication in someone with cirrhosis, you are monitoring them extremely closely so that you can change course if there's evidence of worsening liver disease.
Thanks, Vanya. Any others?
Yeah, we talked a little bit about this in grand rounds yesterday. I just begin with, it's a very open conversation with the families. I go back and even talk about with the Lumacaftor ivacaftor case that there was a patient who expired shortly after initiation of therapy, even though it's not necessarily the same drug, just the ivacaftor component's still there. I've had a patient even the last week that was started that had cirrhotic disease since the new recommendations came out. We discussed them. But as I discussed a lot yesterday, unless there's signs of synthetic dysfunction, I still believe that these medications are safe. And if their lung function is 100%, they're doing great and they're hesitant, I totally get it. It's not a soapbox for me. But if there is some real signs that this can improve their lung function, I mean, we all hear how great these kids and these adults do after starting this medicine, and I hate to take it away from them when I think that they're going to do well with it. So again, I guess my soapbox with this is if you see any signs of synthetic dysfunction, take it seriously. It might just be a subtle bump in the bilirubin, but otherwise, if it's just a small bump in the transaminase levels, at least anecdotally and what we can tell from the data that's out there, the mass majority of these patients are going to do very well.
I completely agree with that. And I think even from the adult perspective, as an adult hepatologist, the same thing obviously holds true, which is there can be tremendous benefit from these medications. And one patient who I evaluated recently does have cirrhosis, portal hypertension, but remains compensated. Bilirubin fluctuates a little bit, but it's indirect. And even then, there's a lot of subtlety there as to whether this is real synthetic dysfunction or not. But the improvements to the lung function is phenomenal. And honestly, I think for future needs to have a well-preserved lung function will be very helpful for the liver outcomes. And so certainly we don't want to dismiss that improvement. I have to say that it really probably involves the need for very close monitoring, though, on a regular basis with dedicated GI or hepatology. I mean, the development of some ascites fluid, even around the liver, that's not very clinically obvious, but on imaging would be one small subtle finding that could be relevant. So I do think careful specialist-based monitoring is going to be really important for these patients beyond the general CF ongoing care.
Absolutely agree. We have a modified protocol for monitoring these patients at our center. I'm sure you guys all do as well. It's not evidence-based, but it's, I guess, common sense-based. So as long as you have a good plan.
Yeah, thank you. I think that, the last comments are really sort of key, right? We're just starting to learn more just about, even CF, so the liver involvement, even without modulators, and then putting on top, modulators and how those may monitor. So I think that it really is imperative to engage with, pediatric gastroenterologists who are very familiar with the nuances of liver involvement in CF, or dedicated hepatologists that are also involved with, aware of those nuances. And if you don't have someone at your center, I would encourage you to reach out to nearby centers, or even those that are far away. Oftentimes, I know I've given some advice to others, even at a distance. It's of course limited, but still, I think we've got a great community of people that can help. Just to follow up on the conversation, what do you do if you have a patient that has persistent elevations in their LFTs after discontinuing Trikafta, but normal synthetic function and normal imaging? Do you do further workup? Do you do a liver biopsy? Do you put them back on? Again, any other sort of advice? I know we can go through 1,000 different scenarios, and we won't do that all today. I know we're getting some of those questions, but I think it does, this one at least worth mentioning.
So I can take a stab at that. I definitely would look for other reasons for LFT elevations. I don't know if this question in particular, if the patient had elevations before they started Trikafta, but if they had normal function in the beginning and then they have an elevation after they've been on the medication, I would certainly expand the workup to include the other possible differentials for hepatitis that can affect any of us. So that's where I would start. And liver biopsy, if there can be indicated, although is notoriously a little bit patchy in CF disease. So I would reserve that if the questions still remained over time.
Vanya, there was a question about the importance of looking for alpha-1 antitrypsin after your talk. And so if you could comment on that as part of the workup.
Yes, the heterozygous states in alpha-1 antitrypsin deficiency are noted to compound effect with CF liver disease. So in any patient who has a persistent elevation of their liver tests for over 6 months, I will send alpha-1 high phenotype and alpha-1 antitrypsin level, just so that we know if there is any additional confounding liver disease. Alpha-1 antitrypsin deficiency can lead to a sensitivity, essentially, of the liver from buildup of the alpha-1 protein in the liver.
Thank you. And I think it's a good reminder that regardless if someone is on modulators or not, that there are recommendations on doing workup for various other causes of liver disease and CF. Just because you have CF doesn't mean you can get some other cause of liver disease or have liver toxicity from medications beyond modulators. In fact, before modulators, we saw this very often, especially with antifungal agents and other things where we would get elevations in these enzymes. So, I think that we need to keep the lessons that we were learning before modulators and add these additional ones in, and not always blame modulators, but it does add another dimension, for us. Okay. Maybe shifting gears a little bit, I think this can go to several people, but if you want to comment on experience in using non-selective beta blockers in patients with varices and cirrhosis, and how that may practically impact, lung disease as well.
So I think in using non-selective beta blockers, the data in children is very sparse, and then in adolescents or adults, they recommend using the same. If you're asking the question in relation to non-cirrhotic portal hypertension, we use similar data from cirrhosis, cirrhotic portal hypertension, to use beta blockers in non-cirrhotic portal hypertension also. But in pediatrics, there's no data on use of beta blockers in esophageal varices or as a preventive strategies to prevent bleeding, variceal bleeding. I think that's what I'm aware of.
Yeah. David, do you have any comments as an adult hepatologist?
Yeah, I mean, in adult hepatology, obviously, we're very predisposed to the non-selective beta blocker therapies. I'm sure my other colleagues do the same, which is frequent communication about each individual patient with the rest of the CF team. And when these situations arise, I very quickly speak to my pulmonary colleagues about the status of the lung disease. And many times there is no concern whatsoever. So I feel like it's often a conversation with the rest of the team. And in principle, at least in adults, I have not seen cases in which we were unable to offer that, although it obviously can occur. So I'm really predisposed to non-selective beta blockers unless there's a contraindication for my lung colleagues.
Thank you. Multiple talks touched on labs and specifically GGT. And so there were some questions. One about that. One was, should GGT be checked with annual labs? Question specifically for adults, but I will sort of expand that to, should we be checking it in everyone? And then maybe as a secondary question specific to the adults, how does GGT and alkaline phosphatase correlate, as alkaline phosphatase is more commonly tested for in the adult population?
Well,
Yes, GGT should be checked. Go ahead, David.
Yeah, I agree. I mean, of course, I have to take off my hat as somebody who treats a lot of patients with cholestatic liver diseases, for where I do frequent monitoring and trending of GGT to a general population, of course, which we're talking now of patients or persons with CF. I do think that despite the fact that GGT has been understudied in adult individual populations, not just for cholestatic diseases, frankly, but also for CF, doesn't mean that it should not be evaluated. So I have a very low threshold to do that. I think it's very helpful to get a sense for any even mild degree of cholestatic inflammation. Of course, if the GGT is above normal, but the alkaline phosphatase is near normal or fully normal, of course, is one of the questions always comes up in medicine is what are you going to do about it? But I think as we evolve, we probably can move toward early identification in adult patients who have this as a marker, perhaps of more significant or potential future significant CF liver involvement. So I am in favor of that, although acknowledging that how this fits into the algorithms for adults is not yet established.
Thanks. And, Meg made a great comment as a reminder that GGT is often not included in many liver function panels or metabolic panels. And so you may need to specifically request that to be added in. And I know at our center we had, we've had conversations about that over the years, where our standard metabolic panel, which would measure, bilirubin, AST, ALT, does not include GGT. So specifically putting that in. So I think it's important to remember that and have a discussion about that with your center. Great. Okay. Here's, there were couple of talks and mentioned ursodeoxycholic acid. It's always a topic of conversation when we talk about liver involvement in CF. And maybe we'll start with EJ. So do you think the ursodeoxycholic acid debate is over? Is there any role for ursodeoxycholic in CF?
Yeah. It's a great question, and one that obviously I think we all have to address at some way or some level. Is the conversation over? No, I don't think it is. I think people are going to continue to use it. I myself use it on occasion. I'm not going to pretend like I don't. I definitely use it for anytime I see bilirubins increase, because that's the main indication of the medication. But in some ways to make the patients feel better, in some ways to make my colleagues feel better. For some of our patients on modulator therapies, we will put them on the medicine just so we can get those numbers down to below that 3 or 5 times the upper level of normal. I don't think it affects overall health. I don't think it affects their morbidity or their mortality. That's just my belief. That's what the data so far shows us. None of the data is great or perfect for sure. And it's a very low side effect medication. I mean, remember, it's essentially a brown bear bile derivative. I mean, it's pretty natural, really. And so knowing that it has very minimal side effect, and if it does make peace of mind better, anxiety better, to get numbers into the 50s instead of in the 90s and 100s, then sure, it still has a role. I know there are some other medications that are being looked at. I'm not really at liberty to discuss much further than that, but there may be some other things coming down the pipeline that may be of benefit in this space. But for right now, for some patients, I can see where Actigol still has a role.
Anyone else have a comment? Sarif, yeah.
Yes, I think there was a question from a parent about ursodeoxycholic, and I think parent, his son or daughter was diagnosed with non-cirrhotic portal hypertension. Was there any role on ursodeoxycholic in non-cirrhotic portal hypertension? I think because, as I mentioned, the pathology in this is a vascular cause, so not biliary cause. I think, and then GGT and alk-phos being normal, and even some studies have shown serum bile acids are also being low or normal, suggesting it's not a cholestatic disease, non-cirrhotic, at least at the beginning. So there's no role for ursodeoxycholic in obliterative portal venopathy or non-cirrhotic portal hypertension.
Thank you, Suresh. I think that's a important point, and I think it highlights us, having a good understanding of what may be going on in the liver. Right? Is that not all liver involvement is the same, and so understanding that can be very helpful not only for prognosis but also for potential treatments. I mean, I will admit, Jay, I've taken sort of a similar approach that I figure, even if it helps keep the labs low and allows people to stay on their modulators, then that may, be the primary benefit of it, even if it doesn't directly impact, the progression to sort of advanced disease. But I think this is going to be a longstanding conversation, and I don't anticipate there's going to be any randomized, trials, with this. So I think the question will always kind of linger, maybe in the background for a while.
I do too. And I think if we look at the European data, where I think there was actually a little bit more propensity to use this medication early on, especially by maybe some of the more senior people, I think them coming through with this last study that I showed, sort of showing no difference between the high prescribing groups and the low prescribing groups, I think is probably going to preclude any, like you said, RCT or anything. It will continue to come up. I don't know we're going to get a lot more good data though.
Okay. Yeah.
Also, I would just add that for the subcategory, the smaller percentage of patients that have large ductal strictures, although not in an obstructive setting, you could make a case that in some of the subphenotypes, there may be some value just to prevent biliary stasis. But broadly based, I completely agree. So it's not going to be a game changer.
Great. Thank you. We have a question that wasn't, I think it's sort of directed to everyone in a sense, but as rates of obesity have risen in people with CF, does anyone want to comment on the impact that obesity can have on various types of liver disease and CF? And is the steatosis because of a CF driven process? Is it, separate, and, what is the linkage, and how is that impacting development and or progression of disease? Easy question.
Yeah, it's a very, I think, Zach, you sort of said something a while ago that I think is important, and I hinted at it, to say CF liver disease or to say steatosis is sort of a common pathway, but the way you get there may not be the same, right? So for a long time, there was ideas of fatty acid deficiencies leading to steatosis and CF, some work with normal weight obesity and, lack of lean body mass, and now with true obesity, I think not all steatosis that we see is the same as well. I think that as you add obesity, it is another liver risk factor, and it's going to add more variables that are going to make an already pretty complicated picture more difficult to tease apart, but not impossible, especially as we use more of the imaging that David talked about with, sort of LSM and, CAP through VCT and other things. I will say that for a long time, I think we had this idea that steatosis and CF did not progress like we see in NAFLD to that sort of NASH and onto fibrosis that is sort of epidemic everywhere else in our lives. But if you actually look through the data at PUSH that is published now, and you look at some of those patients that actually had a homogeneous pattern suggestive of steatosis, there is a small subgroup there that did go on to develop a nodular pattern. Certainly not everybody, certainly not like we saw in the heterogeneous population, but there is a weak signal there. And to me, again, that just goes to the idea that it's going to take monitoring, because it's going to be very difficult, at least for now, to tease apart which steatosis we're dealing with. And that's sort of my take on it. I don't know if others agree or have a different take on it.
I'll make a comment. One of my fellows, and this is unpublished data, but looked at the incidence or prevalence of PNPL3, which is associated with NAFLD in the general population. We looked at CF patients, and the prevalence is similar. So I don't think there's an increased risk necessarily, but I think we need to be aware of the fact that obesity is going to contribute to liver disease and think about it as we evaluate these patients.
I would add the one study, which was a small study that I had referenced in the talk, also gave perhaps some insight, although clearly there's more that we don't understand to the steatosis phenotype in CF liver involvement. But In patients who may have fatty liver unrelated to CF, oftentimes I think perhaps the phenotype of those patients is different, such that in some of the patients who had fatty liver, which is not attributable to CF, they did not have pancreatic.
I think we lost David there for a second. Okay, we'll let him come back on once his connection improves. And so I'll save a imaging question until after he's back on here. Let's see. So there's several questions about Trikafta and elevations in bilirubin and sort of indirect elevations. Also Gilbert's and how, what do we do with that? Maybe Vanya and then others can sort of comment on how, specifically Trikafta, I think, can affect different types of bilirubin, and what do we do with that when you have elevations and maybe an unconjugated?
So for unconjugated bilirubin, I do look for other etiologies of where that could be coming from. So in particular, G6PD deficiency. I've had a few patients with an indirect hyperbilirubin who have ended up having G6PD deficiency, looking for signs of hemolysis. But I think in the setting of Alex-Tezaiva, it has to be taken seriously. So looking for other, again, going back and looking and making sure that there's no other underlying liver disease is important with those patients.
And I think I have to add, because I think I answered the wrong question yesterday. I think I misunderstood. I think there was a question about OAT beta in particular as it relates to indirect bili, and I had heard OST beta and whatever, slightly different, talked a little bit about inflammation, impairment of bile acid transporters. Lexicaftor particularly is known to be an OAT-B suppressor, which may increase your indirect bili. So I think a lot of us have seen increased indirect bilirubin in that 2, 3, maybe even 4 range. Doesn't seem to be sustained. As long as the fractionation comes back, there's no signs of any other liver disease, and it is a predominantly indirect, then yes, I've continued patients on medication without any problem. Some for well over a year now that have had mildly elevated indirect bilirubins.
Thank you. I'll start this question with Suresh. Suresh, during your talk, you mentioned getting a CT scan potentially for the evaluation of bilirubinopathy in CF. One of the questions was, when do you make that decision to get a CT scan? And can you comment on getting CT scans versus MRIs, and what are your preferred modality specifically for diagnosing non-cirrhotic portal hypertension?
I think that's Zach, that's a very good question. When in evaluating for any evidence of portal venopathy, once we, as I mentioned in my talk, if we see in the clinically, if there's a huge spleen and marked pancytopenia, and then when you do imaging, you don't see much of heterogeneity in liver parenchyma, then there is disproportionate, significantly high portal hypertension compared to what we see typically in cirrhosis. Then we proceed with imaging. If the question is either CT versus MRI, I would prefer a triphasic CD where you can do arterial phase, venous phase, and portal phase, and they can give a good interpretation. The main thing in CT is to look for is if the portal vein and splenoportal access is patent or not patent, especially the portal vein, and also the hepatic veins are patent or not patent. And then the next thing we ask is, what about the intrahepatic portal vein branches? And then if you're having a good radiologist and if you have a good triphasic CT, they can easily see the findings which I described, where there'll be like a thickening of the portal vein, and then some calcifications, and in some, the most important feature is the step-down pattern, where you can see as a portal vein branches further down, and you can see a narrowing of the smaller to medium branches of the portal vein. So I would say I would prefer CT, triphasic CT compared to MRI for this, diagnosing this part of this obliterative portal veinopathy and non-cirrhotic portal hypertension.
Yeah, thank you for that. It's, this is an area that is getting a lot more attention in CF, and I think we're sort of working through it. I know that personally I had a patient that on an MRI tended to have a lot more sort of fibrosis specifically around the portal vein, right? And then had portal hypertension. So given that liver fibrosis can be very patchy in CF, you know, at the time at least, we wondered, okay, well, is that just sort of where the patchiness is? And that's why it's explaining so. But I think that, you know, these questions about non-cirrhotic portal hypertension and the further evaluation through something like CT can, you know, be helpful for us. So thank you. Okay, David's making his way back. I'm going to follow up with another imaging question here that maybe Jay can comment, and then also David. So in imaging and CF, specifically about ultrasound, there have been multiple different studies done, obviously. And in the PUSH study, for example, there was very nice sort of delineation between homogeneously echogenic and heterogeneously echogenic ultrasounds. I know at least at our institution, and I know I'm talking with others, that clinically our radiologists don't tend to sort of really delineate to that degree, and they may just say it's echogenic, which is why we use that for our studies. So my question is, can you sort of comment on how do we move forward on using ultrasound echogenicity in this space? Are there lessons that we can use for our clinical interpretations? Do we need to alter how our radiologists are reading these scans and provide sort of different education? You know, yeah. So there's the question.
Yeah, I think it's a hard question to ask, because I think in the back of your mind, Zach, you know how hard it is to answer as well. I think if you look at the PUSH study and the language that we've used, we're always very quick to state that we are not recommending broad strokes here of everything getting an ultrasound. And we also highlight that every ultrasound is read by 3 and then usually a 4th radiologist who have all undergone specific training for this study. It has been well shown in a number of different diseases that intra and inter radiology interpretation can vary significantly. And so I think that's one of the other reasons why you can't just say everybody gets an ultrasound every year, or, you know, all this other stuff, because it is a lot of nuance here and understanding. And as with anything in medicine, the more you do, the more comfortable and better you get with it, right? So I still think it's a great screening tool. I personally like FibroScan a lot, but I also understand, especially in pediatrics, that the utility the availability of it is extremely limited as opposed to our adult colleagues, who it's almost like a vital sign for them. And so that's why I say it really is a combination of all these things, and really what you have available at your institution and your center that you have the most faith in. I'm fortunate enough to have a great radiologist who's a part of the PUSH study, and she's looked at hundreds of ultrasounds of CF patients. Not everybody has that luxury, and I understand that. So for somebody else, there may be a quicker knee-jerk reaction to get to MRI. There may be some more heavily, bias towards labs. But I think that's why we can't just kind of give a pat answer for every center. This is the right way. This is the right approach. It's person dependent, it's center dependent, at least for me at this point. So hopefully that sort of gets at your question.
David?
Yeah, so thank you. It's a great question. And I completely agree with Jay. I have to say that maybe we're not there yet. We're never as far along as we'd like to be. But I think that the utility of a non-normal ultrasound, which might be the way of thinking about it, probably then depends on the other data that we may want to collect and have available. That's particularly why I like the line of thinking from your algorithms, Zach, and others who are approaching it from this way. A non-normal ultrasound in the presence of an elevated GGT and or some calculated risk scores probably means a lot more than a non-normal ultrasound in the setting of near normal or normal labs and without any other clinical or calculated risk score concern. So I think to tease apart perhaps one small aspect, which is an ultrasound subtypes may be less clinically relevant, but in combination with other factors, I think it does still retain importance. So I agree with Jay that it's important to obtain the ultrasound and then take a non-normal finding in the context of what else is going on.
One small addition to this as well is there is more use of RFE and shear wave elastography, especially with your normal B-mode ultrasound. Remember that these are vendor dependent values. So the cutoffs cannot be directly compared sometimes between ultrasound vendors, or definitely between the ultrasound vendors, and can't be compared by MRI or VCT either. They're all independent. So they do tend to trend in the same direction, but there is no one-to-one comparison, at least as of yet.
Yeah, I think that's an important point. And study we did, we also found that the probe you use matters, as well. Or it's been used in multiple probes, and so that can be important. And I think that what many of us are coming to appreciate is that it's really important to see over time, those changes, and then that person becomes their own sort of control rather than a sort of global values, because I know there is a lot of confusion about, there are different numbers in the literature and studies, and people use slightly different types of elastography, and so that can be hard to synthesize all of that. Speaking about thresholds, and multiple talks talked about fibrosis indices and utilizing them. And I know this is a topic of interest both for screening for liver involvement and monitoring. Yes, one thing that I know comes up is to do this is we've looked at the literature and done our own studies. Is that since especially APRI and GPR use upper limit of normals to be calculated, what you use as your upper limit of normal is going to change what the end result from that formula is. And so I guess two things. One is really a comment more than a question, is that I think it is important as you look at the literature to, look in the methods and see what did they use and how does that compare to what you're using at your institution, so you can actually interpret what thresholds you may be wanting to use and not just take them at face value. But I think the other is, Vanya, you commented on sort of the studies by, Swimmer et al., looking at ALT, but there are also other studies out there looking at normative values, for our other liver enzymes. I don't know if you want to comment on any of those, or, but I think we all recognize that it's important to use appropriate thresholds that may or may not be what your EMR pulls up as.
Yeah.
Normal.
So, the Caliper database, the Canadian laboratory pediatric reference values are something that I use for the looking for age and sex-specific norms or reference ranges for pediatric patients. And that database does have, I think it's over 12,000 patients now, healthy patients that have provided samples for their normal values. So it's definitely important to think about the lower values that are considered normal in pediatrics in particular.
Thank you.
Kind of to piggyback on that is, if you look at APRI, FIB4, some of our other markers, and compare those to hepatitis B, hepatitis C, NAFLD, other liver diseases, a lot of times those reported thresholds are lower than we're seeing in other conditions. And with that in mind, we've all shown some data for platelets in particular, and notice that for like biliary atresia or something like that, we may not care until platelets get to 50 or 70 or something like that. A patient whose platelets go from 350 to 100 in CF scares me, because they may have higher platelets as an acute phase reactant or whatever the problem is. So know that those sort of conventional cutoff values, they may have to even come down lower. Your threshold has to be lower in CF.
Yeah, I think that's an important point. And I'll just put a plug in that we've also seen that with some of the CFTR modulators as platelet values change due to systemic inflammation and such, then we need to take into consideration. So our time is up. As anticipated, we've had a great discussion about a lot of topics. We could continue to go on, but we'll hopefully continue this offline. Again, I want to thank all of our speakers, my co-moderator, Meg Sate, and thank you to everyone who's joined us today.